So I'm going actually to ask Professor Talal to tell his nice word again, because this is mostly for you, because it started at the time that you were the president of Asian Pacific Endodontic Confederation, and when Professor Abu Tahun was the dean of the educational committee. Professor Talal, please. Now we are recording your voice for that.
Oh, yes, of course. What I was mentioning that really during the COVID pandemic, we all sit down at home. So we had a lot of, webinars speaking about different topics. But here was something different. Here, even the lecturer, even everyone will sit down and learn a lot. Because, here we are speaking to minds rather than we are speaking over a certain technique or maybe sometimes making promotion for certain products. But here it was very, very rich of scientific information. We learned a lot. I encouraged my postgraduate students to attend too many times. And as you know, from the beginning, I keep to follow all the journal club. And the most important thing that why now we reach to this level of sponsoring, and people, they want to attend, and people, they want to share their manuscript because actually of Professor Nikofar. He insists, and I know that he ran into a difficult timing of I think maybe he was bored. He was, sometimes you don't find the support, but insisting was the most important, and really hat off for you, Professor Nikofar, for continuing, and we keep learning from you. Please keep it going on. Don't stop.
Thank you. Thank you very much, Talal.
Mohammed, I want to second this opinion, because without you, we wouldn't have great sessions like these. You are from your genes. You are born to to design these sessions. I'm really grateful for all the sessions. We are discussing pure science. We have no personal profits or benefits from this. And I hope we will continue this in the future. And I think it will be very helpful for all postgraduate students.
Thank you very much, guys. You have spoiled me. Thank you very much. Thank you. So we still have 9 minutes to officially start. I'm sure Antonis is going to join us as well soon. Okay, sorry, I just contact Antonis, so he's going to join us very soon in 2 minutes. So we are going to start. Yes, I think he is in now.
My voice is clear?
Yes, Viresh, do you want to say something? We check your voice, that would be good.
Okay, first of all, I would like to thank everyone, right? And secondly,
oh yes, Antonis is here. Hi, Antonis. So Viresh, you can call with talk with Antonis.
Hi, Antonis.
Hello, how are you? Can you hear me?
How are you? Yes, yes, can hear you, and I can see millions of International Endodontic Journal at your back.
Yes. Viresh, the quality of your voice still is not very good, but I think we cannot do anything. Let's carry on to see what happened.
I hope for the best. Otherwise, in the middle of it, I will try to change the room. Otherwise, because I've already changed now.
Okay, all right, perfect.
So, Antonis, today you are on the hot seat today. I said today you are on the hot seat.
Ah, me? Yeah. Yes. Yes. Yeah, I'm glad
you should be ready. You should be ready, Antonis. Today is actually a very severe day for you.
Okay, it will be a nice discussion on that. I'm
yes,
just
of course.
Wrote on.
I think now we can almost be ready to officially start our 16 online journal club. Yes. Hello, everybody.
Okay.
We are starting our 16 online journal club, which is actually a mutual work between the Educational Committee of Asian Pacific Endodontic Confederation and Tehran University of Medical Sciences. According to a contract between Tehran University of Medical Sciences and Asian Pacific Endodontic Confederation, we are hosting the online journal club discussion in which we select an article, a recent article, which is published in prestigious journals of Endodontics, including International Endodontic Journal and Journal of Endodontics, Australian Endodontic Journal, and other worldwide or internationally endodontic journal, which is published around the world. And in this innovative program, which is a start actually by inviting Professor Venkatesh Babu, we start actually criticizing and critically appraised the publications in the presence of the first author, or sometimes first author, corresponding authors, and other authors of the articles. And most of you following our programs until today, and today we are very proud to say that this is the 16th program of our online journal clubs. I have to say that I really appreciate the support that I have received from all of you by joining us in this program, because without you, it wasn't possible to run such a things. It was at the time that Professor Mehmet Bebra Kayahan, my brother, my very close friend, was the of Asian Pacific Endodontic Confederation, and we started the program. And at that time, Professor Ibrahim Abu Tahun, the lifetime member of Asian Pacific Endodontic Confederation, one of the axis of APEC, was the head and the dean, and also the founder of the educational committee as well. So before we officially start, while we are waiting for other colleagues to join us, I'm going to ask Professor Kayahan to give us the opening talk. Please unmute yourself. Please unmute yourself.
Thank you very much, Professor Nekofar. It's a pleasure to be here. It was pleasure, really my pleasure and honor to sign that agreement between Asian Pacific Endodontic Confederation and Tehran University. That's really success, starting of the success of successful days. I'd like to thank you once again supporting this and be the head of this organization. Thank you very much. I'd like to thank all members and all participants who are here, and I'd like to thank Dr. Antonis Chaniotis and Dr. Viresh Chopra, and I'd like to thank all my colleagues, Professor Tahun, Professor Miglani, Henry Kim, and thank you very much for being here. Please, the stage is yours. Thank you very much.
Thank you very much. Professor Abu Tahun, you go ahead, please.
Okay, thank you, Dr. Mohammed, for organizing a special session with two special persons. The first author, the main author, and the appraiser. And I think it is my duty first to welcome a very dear brother and friend, Dr. Antonis Chaniotis. He is coming from Athens, where I left my heart a few years ago to beat, and still beating in Athens. Discussion of this topic has received great attention and by many researchers and practitioners. As when a tooth with a necrotic tooth with an immature open apex, we are dealing with this needs root canal. We usually go for regenerative endodontic procedures. On the other hand, there is a risk of external root resorption during the movement of these teeth. So the question always remains, do we know everything about this procedure? Primarily, the answer is no, as many gray areas still need to be investigated in this regard. So let's begin, and allow me to address my brother Antonis in Greek. Antonimo, the stage is open for you.
Okay, thank you very much, Professor Abu Tahun. So we are going to start. Dear Antonis, what we are going to do with you today, Oh, assalamu alaikum. Professor Hussein Al-Huwaizi from Iraq is also joining us. Thank you very much, Professor Hussein, to join us. And I'm going to ask all the participants, if possible for them, to turn on their videos because it gives an opportunity for us to communicate in a better way when we see all of you. Thank you very much. We have a lot of participants, a lot of friends from different countries joining us, from Iraq, from Turkey, from Syria, from Greece, from India, everywhere. And it is amazing. From China, we have somebody today, and everywhere. So that's great. That's great. Okay, Antonis, what we are going to do, we are going to forget all of our friendship. So from now, we are going to discuss science, and we are going to be very harsh in this program. Most of the time, Professor Ibrahim tried to make me quiet and not to be very harsh. I'm joking, don't worry. But I'm sure Viresh is going to almost criticize you, and I'm just witnessing the situation. It is the matter of critical appraisal. It starts in Oxford by giving us the methodology of looking at the evidence or evidence base and how to evaluate the publication in the field of the evidence-based medicine and evidence-based dentistry. Because obviously we need to make sure that we screen and select the best information. So far, we ask a lot of colleagues, a lot of professors from around the world, and you can see some of them with us as well. I can see Dilek, I can see Buchin, I can see Fatma Betul. All of them did same thing for us in different sessions. So today, Viresh is going to do that for Antonis. We are very close friends, guys. So whatever we discuss with each other is science. So if Antonis, you want to give us an introduction, please go ahead. And then Viresh is going to share his PowerPoint with us, this explaining your publication for everybody first. And then he is going to ask you some question, and other participants also is going to ask you direct questions, or they may send something in the chat box. Antonis, please.
Hello to all from Athens, Greece. It's a great pleasure and honor for me to be with you and to see all of nice friends online to discuss one of the most important topics nowadays, that is how to handle successful regenerative cases when it comes to the long-term follow-up and orthodontic movement, or even we should also think about the restorative part of regenerative endodontic procedures in the long term, when we are thinking in the long term. So I thank you for the opportunity to be with you. You know, I'm mostly based in private practice. Although I work with a lot of universities, I like to be to cooperate with university, but I'm private practice based here in Athens. So before I start, I have to tell you that since the beginning of the early days of regenerative endodontic procedures, I was really stimulated and enthusiastic about this new, at least in my mind, back in 2008-9, it was a relatively new horizon on the treatment of necrotic immature APECs. So I started since the beginning of trying to treat cases with necrotic immature root with a different approach, that is the regenerative approach. Until 2008, 2009, all of my necrotic immature root cases received apexification procedure, or after the introduction of calcium silicate cement, usually I used to try to perform a single step MTA plug and restoration in the same or next appointment with fiber posts. over the MTA in this kind of cases. But for the first time since the 2008, I believe, and in this publication, you will see one of my first attempt to use regenerative endodontic procedures for the management of a necrotic immature root. I started dealing with this procedure. In the beginning, as you all know, the information was sparse, not too many things that we knew about this technique. And then we started the research and publishing about the requirements for a successful endodontic procedures. Then the American Association of Endodontics and the European Society published guidelines on how to manage cases with regenerative endodontic procedure. But you have always to keep in your mind, when my good friend Viraj Chopra will discuss our paper, that these cases started long time ago, when in a time when the knowledge and the published literature, the available evidence at that time was limited, mostly originating from case reports, and we were starting to researching about regenerative endodontic procedures. So you will, in Athens, I run a practice that I'm limited to endodontics mostly, but I have, although I don't treat children, you know, the pediatric dentists in Greece, usually they don't want to deal with problems of the pulp tissue when it comes to permanent teeth. So they always would like to refer to an endodontist to try and figure it out how to save a tooth once the pulp becomes infected or necrotic. So I had the chance since the early days receiving a lot of referrals of young patients around the age of from 6 to 9 years old after trauma, that I had to manage an immature mostly central incisors with necrotic pulp tissue and usually a periapical lesion. So in all these cases, that some cases I treated them with apexification or MTA plug procedures, and other cases with regenerative procedures. I always would like, I always like to long-term follow up these cases. I believe it's very important to follow our little patients as they grow up, and look at the result of our efforts, and this will just make us better doctors. So under this idea, you will see that in this paper, we put on the paper some very long-term follow-ups, like 11 years and 8-year follow-up, 11 years and 4-year follow-up of regenerative cases. And actually, you know, sometimes it takes, whenever things go the right way, it's actually, we are happy, we publish the case and we get the compliments from our colleagues. But it takes a lot of effort and a lot of courage to write in a paper some complications of our treatments. So actually what we did, we, since I had all these I have all my cases documented under my microscope, and I keep the files. I had the privilege of being able to follow up some cases for so many years, and ended up to see that we have, although regenerative endodontic procedures are a really hot topic nowadays, and I'm still practicing regenerative endodontic procedures, I have to tell you that nowadays I'm more skeptic about this because I started seeing some long-term complication of my early attempts to deal with this treatment approach. So
yes, and I don't want to Antonis, sorry to interrupt you. I think today we want to emphasize on application of the orthodontic forces. So let's start by sharing what Viresh is going to tell us, because we want first to make sure that all of our participants know that what had written in the article. Viresh, please go ahead and share your PowerPoint with us. I have to make sure that I moderate the time as well. Therefore, sorry for interrupting you. We will come back to you, Antonis, for the discussion. Okay, Viresh, please.
Good evening, good morning. Afternoon.
I think, Viresh, we cannot hear you very well.
Everyone.
Problem with sound.
In every part. Hope am I audible now?
Yes, yes, yes.
Yes. So
we already actually check the line with Viresh in today morning, but unfortunately it seems that your connection is not good, Viresh.
Good evening, good morning, different. I'll just let me see if we can work somewhere here.
Yes, good. If you be close to your modem, maybe that makes it better.
Is it audible now?
Much better, much better. Yes.
Okay. So I would just say good evening, good night, good morning, good afternoon to everyone in different parts of the world, and thank you for joining in for this journal club. And I am really fortunate enough to be the critical appraiser for this, because this article is somewhat, I believe, a very good article to cover up the gap between what research shows and what is clinical endodontics, what we do in clinical dentistry. And like my dear friend Antonis said, that it takes a lot of courage to present complications and failures, right? So first of all, I would like to congratulate Antonis by saying that thank you for publishing this article, right? And giving an insight to what can happen even after achieving success with regenerative endodontic procedures and how we should be careful. But by that, I don't mean to say that I will be very friendly to you, Antonis. So you are on a serious hot seat today, right? And let's see how it goes. And we'll have a fruitful discussion today. So the article which we are discussing today is long-term complications of previously successful regenerative endodontic procedures after orthodontic movement. This article basically presents a report of 3 different complications after 4, 8, and 11 years. And when basically, I firmly believe when you are doing a clinical practice, it's a very good sign of your efficacy if you have such long follow-ups for your patients. So it speaks a lot about the type of clinical practice a dear friend Antonis is having. So starting with this article, the basic aim of this article is to report 3 procedures to report 3 cases of previously successful regenerative endodontic procedures with long-term follow-up that developed different complications after the application of orthodontic forces. So a very critical point here is that what should be done in terms of orthodontic treatment if the teeth after having regenerative endodontic procedures have to undergo for orthodontic treatment. To start with, in necrotic immature permanent teeth, we know that conventional endodontic treatment procedures might be challenging to follow. The thin dentinal walls, the shortened root length, the wide canal, and the absence of an apical stop render the disinfection and obturation procedures difficult and unpredictable. The defective crown to root ratio in combination with the thin dentinal walls render these teeth susceptible to fracture. Now here, if I may ask, if you can give me the liberty of asking questions in between. So Prof. Nikuhar, I would like to ask the author here that in the, this is very rightly said that these all factors, they definitely render difficulties to us. But in the era of such latest armamentarium and materials like calcium silicate cements, do we really feel that these factors give us a difficulty, or it is just that we are having this bent of mind from the earlier days when we did not have calcium silicate cements, when we did not have collagen barriers, when we did not have side vented needles, and when we did not have diluted sodium hypochlorite and other irrigants? So do we really think that these factors today also are causing difficulty in root canal treatments or apexification, apexogenesis procedures? What's your take, Antonis, on this?
I believe nowadays with all this equipment, microscope enhanced endodontics and all the techniques and the evolution on calcium silicate cements, we can predictably now perform a single step apexification procedures with the calcium silicate cement. And also we can also predictably clean and disinfect the root canal space and obturate the root canal space. It's just a matter of practicing. And also it's quite a challenge for, in this kind of cases, for the restoration. What you need, I think what you need also to consider is the restorative attempt that you will have to, the restorative procedure that you will need to perform to your case. So nowadays, I believe it's not, the difficulty is minimal. However, this brings all down to the selection of the different treatment approach in cases like this, to, I guess, to the restorative effort, because sometimes these teeth are damaged. The crown is completely missing, so maybe you will need a post for the restoration of the tooth. And if you have cases that you will need a post, actually you cannot perform regenerative endodontics because you don't have space to put to place a post if you place the calcium silicate barrier in the coronal part. So you need to consider an apical barrier technique in such cases. And also there is also a question of that we need to run into our literature and our published data to see what is the available evidence that we have nowadays before we select a treatment approach for this kind of cases that has to do with the reinforcement of the tooth structure. So what is the big question here is if the regenerative endodontic procedures and the will strengthen the tooth structure, or if an apical barrier technique with a composite restoration and fiber post maybe strengthens more the tooth structure that a biological repair after a regenerative endodontic procedure. So all these.
Right.
Yeah, I think in the chat box, Professor Barbara Kohan mentioned a very important things. Barbara, please go ahead and quickly tell us what is your idea.
With open apexes, for example, in blunderbuss apex, it's always a problem. Even with microscope, like we need some internal matrix concept approach. But before it, we always need some apexification procedures or apexogenesis, near apexogenesis procedures like revascularization or regeneration, what you call. That's the important point, I think.
Yeah, so still with all these mechanical techniques, we need the biological technique, because the mechanical techniques cannot reinforce the tooth, even though we have this sophisticated material and techniques. Still biology is very important. Okay, Viresh, please.
That's the point.
Especially in the early stage of tooth development.
Yes.
In the late stage of tooth development, maybe an MTA calcium silicate apical barrier technique can work and be very predictable. But in the early stages, as Professor Barbara said, when we have a blunderbuss apex with minimal tooth length, it's almost impossible to perform an apical barrier technique predictably.
Thank you.
We need some biological procedures.
All right. So till a few years back, calcium hydroxide apexification procedure was the only treatment option available to deal with necrotic immature permanent teeth. However, with the introduction of hydraulic calcium silicate cements, one-step apical barrier techniques became a very popular technique rapidly. And very rightly, yes, we have been able to do these regenerative endodontic therapies quite often now. Recently, regenerative endodontic procedures were introduced for the induction of continued root development and dentine wall thickening of the necrotic immature tooth. However, the important question remains here is that what about the overall orthodontic management of these teeth if they have to undergo the orthodontic management? Now, I would like to ask the author here that when I was going through this article, I came across two techniques, two terminologies. That is regenerative endodontic procedures and regenerative endodontic therapy. By any chance, are they different, or it's just the name has been used? Means, because I read REPs and RET.
No, it's the same. It's a regenerative endodontic treatment or a regenerative endodontic procedure. It's the same.
Because as a reader, I was getting confused that maybe for procedure is like an umbrella and therapy is a part of it.
No,
I think this is very important. I think this is very important in scientific manuscript to be consistent. And I think this this comment is true, that because our student also asks same questions, that why sometimes it is regenerative endodontic procedure, sometimes treatment. But recently, I think, according to the guidelines of both European Society and American Society of Endodontology, it must be written regenerative endodontic procedure, because it is actually it covers actually a spectrum of the treatment modalities rather than just a particular treatment.
Right.
Yes, I agree. We need to be consistent.
Right.
Yeah,
So
this time we should criticize the editors of the journal, not the author.
Right. So immature necrotic teeth have an option of a regenerative endodontic procedure or therapy as mentioned in the manuscript, and they have gone an orthodontic therapy. This manuscript showcases 3 case reports which have undergone this procedure and undergone the cycle of these treatments. And let's see what happens to these cases as we move ahead. Now, this research, they had already mentioned that the orthodontist who has done this therapy, they had done a survey on it, and most of the respondents didn't know how to manage a restorative endodontically procedurally treated teeth. So I think it is really important at this point of time that we should, or the team who is working on it should look into developing some guidelines. Like in the conclusion, the author has given certain guidelines which orthodontist or the team should follow while treating such cases. So it is really important, and thanks to the authors for this manuscript, because it has opened a big research area, which is filling a gap between research and clinical aspect. So it is an area to be actually looked into. Starting with the case 1, 80-year-old white female patient was referred for the evaluation and possible treatment of her maxillary sentence incisors 2 days after suffering an impact injury after a car-related accident. The medical history was non-contributory. I would like to ask an author here, because while going through the 3 case reports, is there any significance of writing a white female here, or is it because it has not been mentioned in any other cases? All other 3 cases, it has not been mentioned. So is there any significance of white here, or it's just again a language?
No. It's just, no.
Okay.
You mean the white female? Why I say white? Usually all
Yes.
of my patients are Caucasian.
No.
If you
Exactly. I totally understand, but I was thinking that maybe case 2, case 3, it has not been mentioned. So maybe it is some, racial division
okay.
or something, geographical distribution, something like that.
No. It's
okay. So the clinical evaluation in this case,
I think these details sometimes are very important, especially for the students that they want to write theses or such a things, to be very, very precise, especially about this type of demographic idea or information. It is necessary to be consistent and follow a very, very severe way for that. So it is good to have this note as well. I think, Antonis, it is also a very important note that Viresh mentioned, and we can accept this comment if you agree.
Of course. It has to, we have to write everything because in the geographic distribution of the patient in some cases play a significant role. And I mean, we need also to be consistent with in scientific reporting, in case reporting, we need to follow the guidelines and report all the data. So maybe
Professor Baber also mentioned that in the chat box that in anatomic studies, obviously we need to be very precise, but in this type of study, when we are speaking about the healing process as well, I think between different ration, it can be different as well. So it may have some genetic background, as Professor Aboutoun also mentioned about the genetic, and he emphasized on that in the previous sessions as well. Okay, thank you, Viresh, please.
Clinical evaluation of the case at the time of initial visit revealed tooth number 11 had suffered an enamel dentine fracture without pulp involvement. Tooth number 21 had suffered an intrusion injury and had been displaced into the alveolar bone, which is clear in the clinical picture here on the screen. Tooth number 11 was slightly painful to percussion. Periodontal probing around tooth number 11 was within normal limits. Thermal and electrical vitality tests were positive for tooth number 11. it was impossible to perform vitality testing on the intruded tooth number 21 because only the incisal edge was visible. Here, if I may, I would like to ask the author that since they said that they were slightly painful to percussion, so immediately within 48 hours of trauma, or you can say 24 or 48 hours of trauma, how much reliable is this thermal vitality test? Means, do we give any place for pulpal inflammation at that point of time? Or is it sensible to do the thermal testing at that point of time, or we should wait for a couple of days more, or 1 week, like they say? So what is your take on that?
Yeah, it's not usually immediately after trauma, the vitality testings are not reliable. However, the initial reading on a cold or hot stimulus or electric vitality testing, a positive response will give you a good indication that the pulp tissue, although it suffered a huge traumatic injury, it still has vital elements inside. Of course, you don't know how things will progress, but at least it's a good indication to make a note in your dental history of patient's dental history that at least we had signs of vitality even after immediately after the traumatic injury. I think it's very important to know that and to document that.
Right. Thank you. So the treatment plan decided was bonded composite resin restoration for tooth 1-1 and spontaneous repositioning for tooth 2-1 at that point of time. 1 year later, clinical evaluation showed spontaneous repositioning of tooth 2-1, but 2 sinuses had developed. Thermal and electric vitality tests were negative for both teeth. Probing depths were within normal limits for both the teeth, and radiographic evaluation showed signs of initial periapical rarefactions associated with both immature tooth. Again, I would like to ask author this doubt, that is 1 year a good enough time to do a recall for such patients, or it should have been done around that 6 months or 3 months interval? Means
no. I think I mentioned in the paper that actually the little girl disappeared from the clinic, missed all the scheduled recalls, and
yes, you mentioned that she missed all these schedules.
Returned only because of the sinus tract. She was worried about the sinus tract. So it's very, very important to closely follow up trauma cases and to follow usually trauma cases. I would like to do 3 months, 6 months, and 1 year follow-up.
Right.
And document everything, the vitality, then to close monitor my patient. But this lady missed all the follow-ups and actually returned just because she developed the sinus tract. So the reason of coming back to the clinic was the sinus tract.
Right. Thank you.
Yeah.
The pulpal diagnosis.
May I just comment on this, please? I think the rationale Dr. Antonis followed is right. We should not rush into any kind of treatment unless there are other signs or symptoms of non-vitality. And this is what he did. Although I'm not sure if electric vitality testing or electric pulp testing is accurate in this age, because the neurovascular complex in patients usually is not complete before, in some patients, the age of 18. So I'm not sure, but I think the rationale is right, although I don't agree with the electric pulp testing, especially that the tooth after trauma is in a state of shock, and the period resolution of shock, it takes maybe up to 6 months or even more. But I think what this has been replaced by the rationale itself, that he waited until patient demonstrated symptoms, and so he could interfere. This is my comment. Thank you.
Yeah, but I
Thank
think, Professor Ibrahim, as Antonis already mentioned, it is important to document everything. We know the limitation of the electrical pulp tester and other types of pulp tester, but it is important and mandatory to document everything. So I'm sure Antonis and all of us know that when we have open APECs, we cannot rely on the result, but we should document it.
Yes, documentation and follow-up is part of treatment. We agree on this. This is.
But Viresh, may I ask you to go to the previous slide, please? In the previous slide, yes, one before, yes. In this one, in figure C, if we look at tooth number 1-1, we can see that on the distal side of the root, we already have the resorption foci on the mesial, on the distal side of the tooth. Am I right? Can you see that as well?
Yes.
In tooth 2-1, you mean?
No, tooth 1-1.
1-1.
Yes,
Okay.
tooth 1-1, and what I can see here, or in diagram B, I cannot see that, but on diagram C, we cannot see such a thing. Viresh, can you show that with your cursor, please?
Pointer.
Yes, with the pointer, please. Viresh, can you show it to us? I think Viresh is disconnected.
This part, I think, is my this one?
Oh, yes, that's it, yes.
Yes.
This area, we already have the external resorption. I think this is very important. Yes, you already, yes, good. Yes, we can now, yes.
I'm not really sure. Maybe it's because of the, I would say definitely we have something happening in the cervical distal wall of the 2-1.
Yes. Yes, cervical, yes. In 2-1 in the distal as well, something like a fracture that you already mentioned in the article as well. Yes.
To tell you the truth, in 1-1, it's the first time I noticed also.
Okay.
So
this is the nature of this discussion. This is the nature of this discussion. Okay,
yeah,
great.
Because
please, Viresh, go ahead. Antonis, yes.
So can I move ahead?
Yes, please, Viresh, please.
Right. The pulpal diagnosis was pulpal necrosis for both teeth, and the periapical diagnosis was a chronic apical abscess associated with sinus tracts on both teeth. A lateral external distal wall defect was also noticed in tooth 2-1. CBCT was advised, but the patient did not want to, could not get it done. Surgical exploration of the defect was also rejected because it would complicate further the treatment procedures. The young patient was extremely uncooperative. Under these circumstances, a decision was made to try regenerative endodontic procedures in both teeth because of the less invasive treatment approach. So this was the protocol that was followed. Buccal infiltration anesthesia was given, rubber dam applied. Tooth number 1 was found entirely necrotic, whereas tooth number 2-1 showed signs of vitality in the mid-root level. Both teeth were disinfected using 20 ml 2% chlorhexidine digluconate solution with minimal instrumentation in a single visit. The thin dentinal walls were lightly brushed with using an ISO 110 Henstrom file, and the dentinal substrate was treated with 17% solution of EDTA for 5 minutes before bleeding induction. Final rinse was performed with sterile water. A sterile ISO 60K file was used for bleeding induction, and these were the protocols for 2-1 and 1-1. Bleeding was successful only in tooth 2-1, and a blood clot was allowed to form at the level of cemento enamel junction. MTA Angelis white was placed over the blood clot and the tooth was restored with composite resin. In tooth 2-1, apical mineral trioxide plug was placed instead. The canal corneal to the MTA plug was filled with injectable thermoplasticized gutta-perca and a pore space was created. The excess cavity was restored with composite resin. Here I have few questions. Can we elaborate on the factors which might be possible of not causing a bleeding in tooth 1-1? Means what do we think that what can be the reason why 1-1?
Usually, to tell you the truth, usually in one of the factors that may impede effective bleeding in this kind of cases is if you use high concentration adrenaline anesthetic solution, which I didn't used here. The other reason actually is maybe a clinical observation that I had is that if you have a long-lasting infection,
yes,
most of the times it's very hard to achieve effective bleeding.
yes,
although if you can disinfect, if you can enhance your disinfection procedure in long-lasting infection, especially if you have periapical rarefactions, you might run into big problems of achieving effective bleeding by the technique of extruding your instruments outside of the apex and lacerating the periapical tissue. So maybe in long-lasting infections that we need to go with a regenerative endodontic procedure, it might be more useful and advisable to use an alternative way like a PRF or PRP procedure, so that you have a scaffold for the stem cells to grow. Because if you cannot achieve effective bleeding and a blood clot, then you might jeopardize the result, the outcome of your regenerative endodontic procedure. At least
Antonis, we need to be careful. The blood clot is not just a scaffold. It is also the source of the stem cells. So if we cannot have this bleeding with PRF or PRP, they are not enough for having enough stem cells. They are very good scaffolds, but they are not the very good source for a stem cells. So for that purpose, we need another alternative for the source of stem cells, which is another discussion. Recently, I think there is a good publication in Journal of Endodontics that they use the blood from other sources as well, circulating blood and other sources as the source of stem cells. We will arrange to have the appraisal of that article, which is published by Ali Nosrat and Trabinejad. So I contacted them. I already choose that article as well. We will discuss that in our future sessions. But I think you already covered the question very well. Thank you. Viresh, please.
Mohammed, may I comment, please?
Please, Professor Ibrahim, yes.
Yeah, may I comment on that disinfection protocol?
Yes,
Dr. Andoni, you used sodium hypochlorite 2%, and you used chlorhexidine. And in many articles, they do not advise the use of chlorhexidine as it is cytotoxic to stem cells. And this might be a reason. The other thing, we are back now.
First, Professor Ibrahim, for this first one, let's Antonis answer. Antonis, please.
Yes, I agree with you. This was also a point raised by all the reviewers that reviewed this paper. But my answer is that it was my initial attempt to get into the regenerative endodontic procedure. The knowledge was not available at that time. The Trevino paper was not even published yet. So the only thing that I had was the initial attempts, the case reports that managed, that started using this regenerative endodontic procedure. And in this initial case reports, some of them used chlorhexidine. So I thought back then, without having the evidence to support this, that chlorhexidine might be better for a regenerative endodontic procedure. Of course, after that, the paper by, I have here, because the Trevino paper about the effect of irrigants on the survival of human stem cells became just published. So at the moment that I read this paper, the Trevino paper, I stopped using chlorhexidine in my regenerative attempts. But this case was my first case. It was 2 or 3 years before the publication of Trevino. And at this point, we had successful regenerative attempts, even with chlorhexidine. They're still published. So after reading the literature and the new information that became available and the new evidence, I changed completely my irrigation protocol, disinfection protocol, and I stopped using chlorhexidine in regenerative endodontic procedure. Actually, nowadays, I'm not using chlorhexidine anywhere.
Yeah.
Okay.
Okay.
I know that.
Secondly,
point, Ibrahim,
secondly, I would
Professor
like to
Ibrahim.
ask
Professor Necrosis, I have a question.
Okay, let's, Professor Ibrahim has his second question, and then we move to Professor Nazari. Professor Ibrahim, please.
Yeah, Dr. Andoni, I know that you are the master of this game. This is your game, the regeneration and especially treating these teeth. I'm discussing this just in an attempt to investigate why failure might happen. But my other point was that you used EDTA. The EDTA, of course, we are back to it now because it releases growth factors. But they are advising now because it also reduces the clot, the blood clot. And they are advising now before to make the final flush after the use of EDTA with saline, so as to prevent this complication. I'm just discussing this because this is what I have found in the literature, and in an attempt to see why we fail. Maybe, I don't know, there are many reasons that might lead to failure, but just I'm discussing the disinfection protocol itself.
Yeah, but the thing is, Professor Ibrahim, I think the most important things about today is to discuss the orthodontic movement and the effect of orthodontic movement. I'm a bit worried about the time. Maybe we are going to have it in 2 sessions because I know the problem is Professor Viresh is going to give us a lot of information about the orthodontic movement as well. So if you let me, I just move forward to go ahead and speak about the orthodontic movement. Definitely, this is a very important topic. We will go back to that. Thank you very much. Professor Nazari Muqaddam, please ask your question or give us your comment very quickly.
Thank you very much. I have a question. Why the author used the number 60 for cause bleeding? As you know, many articles supported by the 25 number of spreader or file. This file is too large, maybe damage the reduced enamel epithelial rest of molasses. That's the main part and source for the epicification and regeneration. And I think this type usage of the file is so harmful, have a detrimental effect on the epithelial rest of molasses. And in another point, if we use this type of the file only about 1 millimeter beyond the apex, it causes damage to the other type of the cells. As you know, during bleeding, about 400 up to 700 type of cells will come into the inside the root canal. and mostly will be died. And only a small part of the cells, as you know, the stem cells will be survive at this position. And I think when we cause the bleeding to this side, is never let to grow the stem cells inside the root canal. Thank you very much.
So the main question is about the size of the file that we overextend from the canal. Why number 60, not 25, as the guideline said? Antonis.
Yes, at the moment when I did I treated this case, I didn't have any guidelines on which file size. Okay. And you know, it seems logical to me that when I am facing an immature root with a huge wide open apex, maybe a bigger size file, a larger size file will give me a more predictable bleeding effect.
So I think what we need to say now, we need to say thank you very much to Antonis to completely say the truth, because it was easy for him to just ignore the details and don't mention that. But it is very important. The author must be like that and completely say whatever happens. We really admire you for that part, Antonis. Thank you very much indeed. Okay, Viresh, please.
The radiographic evaluations through the follow-up period revealed periapical healthy structures for both teeth and gradual continuous root development and dentinal wall thickening for the tooth 2-1. This lateral wall defect remained unaltered through the follow-up period. No periodontal probing depths were detected at any point of the follow-up intervals. 5-year follow-up showed asymptomatic maxillary center incisors, normal probing depths, no mobility. Electrovitality testing of tooth 2-1 showed healthy pulp status. 6 years later, patient reported with excessive bleeding problems for tooth number 2-1. Clinical evaluation, as you can see, the clinical picture showed excessive bleeding from the palatal gingival side of the tooth number 2-1. No discoloration of the crown of tooth number 2-1 was found, but the palatal side was gray with the characteristic appearance of resorbed dental structures. Periodontal probing elicited extensive bleeding from the palatal gingiva. Radiographic evaluation revealed an aggressive class 4 external invasive cervical resorption defect, rendering the tooth non-treatable. So this was the...
Sorry to interrupt you,
yes,
Viresh. I think it's time for Antonis to quickly, in 1 or 2 minutes, answer the second question of Professor Ibrahim. Why you think this failure happened?
To tell you the truth, after following up the case 5 years and doing an electric vitality testing that I got, first of all, I never believed that I can have in a case like this positive vitality response. And I was really surprised in the 5-year follow-up. You can also find the video that I document under my microscope of doing the electric testing on this little girl 5 years after my initial treatment. And I was really surprised to see that she responded positively. Maybe it's because I'm not sure if it's completely reliable because it's still a kid, but it was reproducible, the response, every time I touched with the electrical testing. So I was really happy at the 5 years follow-up that I had my first successful case of regenerative endodontic procedure with a long-term follow-up. And I believe 5 years, it's a long-term follow-up. So I was shocked to see 6 years later, that, and I was really also sad that I didn't continue the following up of this case, and I somehow lost the track of this patient, and just the patient came back 6 years later with this devastating situation. I was really shocked. I asked what happened to this tooth. I mean, I had documented this tooth as one of my biggest success in regenerative endodontic procedure, and now I see a devastating result. And the little lady said that she went on orthodontic movement, and she mentioned that she felt a lot of pain during the orthodontic movement, and I could feel that she didn't have a good cooperation with the orthodontist. And to tell you the truth, in complications, at least in Greece, I don't know how it is in your countries, but when it comes to a complication, when you contact the doctor and asking him, the orthodontist, when I contacted the orthodontist asking him more details about what happens, he was very reluctant to tell me exactly what happened because of maybe legal issues, because the parents usually are complaining. You know, when you have a complication in a young patient, especially the parents can give you a very hard time and starting asking questions, why this happened and who is to blame, and maybe, you know, in some cases you may run into legal problems as well.
Antonis,
so
I think it is also very difficult to make sure what was the reason of the failure, and I think Professor Ibrahim agrees that it is almost impossible to say which was the main reason of the failure. Even orthodontic movement, we cannot blame orthodontic movement easily by saying such a thing. Okay, let's move on.
The long-term complication of the initial trauma. After all, it was an intrusion injury that is very
exactly. And also the fracture line, or that the special defect that Vera showed in tooth number 2-1 in the distal side of the tooth, that can be also the source of the initiation of the resorption as well.
But my main point here, and especially in this paper, is that we need really to continue following up our cases just to make an early intervention when needed. This is very, very important for people to know, that we may run into problems long after the successful case.
Yeah, there is a question in the chat box about the type of the orthodontic movement. Was it a fixed orthodontic movement or removable?
No, it was a fixed orthodontic, orthodontic movement. Actually, this was exactly, I sent an email 5 times, the orthodontist wouldn't reply because he felt that I was accusing him of, you understand? So he didn't want to cooperate with me. So just because it was written, she just sent what I disclosed in the paper. You know, the exchange of information when it comes to complications and cooperations with other specialties, it's very difficult, let's say.
So thank you very much. Thank you very much. I'm a bit worried about the timing, but we have to have a very short break, and by watching some videos from our sponsor. But this time I ask Zohre to mute that, because we have the developer of the device that Zohre is going to show us. Zohre, please go ahead and share the video. And I ask Professor Talal Al-Nahlawi to talk on this video. Talal, please.
Really, I didn't expect. I don't know that you are going to list this description about the kit. The main idea about the kit is to make a collection, actually, about the most useful ultrasonic tips especially changing in some designs of the tips in order to fulfill the up to 80 to 90% of the practice we need in our daily practice in endodontics. For example, here you can see the use of the T1, which is actually something related to a U file, but it is a stainless steel U file. We know that at the beginning, it was introduced to instrument the root canal, and you know how it was disastrous to instrument the canal with the U file and how it can change. But after that, they use it for irrigation activation. Then they discovered it's not good. Also, it changed the internal anatomy if it's used as a activation, so they moved for night tie. But actually the main use for the stainless steel U files is still removal, using it as very, very fine, like a brush, in order to remove calcification coronally, in order to drill around the broken file, regardless of the techniques you are going to make for the broken file removal. This was the T1, and also you can sometimes use it to remove the broken file. And other tips also, that like T2 for irrigation activation for the irrigant, and also T3 we can use it for the access cavity and refinement, removal of the calcification in the coronal part. T4 and the also removal of pulp stones. T5 in the removal of fiber post, and T6 in the removal of a broken file. So this was a video about
Thank you very much indeed.
Thank you.
Professor Talal Al-Nahlawi. Okay, we go back to Viresh to carry on and talking about the application of orthodontic forces. Viresh, please go ahead and share your screen with us.
So starting with case 2, a 6-year-old female patient was referred for evaluation and possible treatment of tooth number 11, which had an impact injury after a bicycle accident 6 months ago. Both maxillary incisors suffered a lateral luxation injury. 1 week before the scheduled appointment, tooth number 11 became painful to percussion and the discoloration developed. Clinical examination showed vestibular intraoral swelling associated with tooth number 11. Radiographic examination showed periapical radiolucency associated with the immature tooth. Diagnosis was made of being pulpal necrosis and periapical diagnosis of symptomatic apical periodontitis. So this was the protocol that was used during the treatment of this case. If I may ask the author here, I just observed a little bit of tweaking of, irrigants percentages here, or the methodology here. Was there any reason of, altering little bit of methodology here in terms of percentages of sodium hypochlorite, and even in terms of, though MTA and bioceramics, you can say they fall under one umbrella, but was there any particular reason of changing the material also here, like not using MTA but using bioceramic?
Of course there is. MTA. My initial attempts to use a calcium silicate coronal barrier in a regenerative treatment procedures was with, of course, with MTA, but MTA had a big problem with, especially the initial formulas of MTA, with the causing discoloration. The new bioceramics got rid of the ingredients that are causing discoloration there. And the main reason that I used now bioceramic, the new bioceramic formulas, is in order not to induce discoloration with the initial formulas of MTA. Of course, some new formulas got rid of the, I believe it is the, see. Okay.
Like
So,
if I,
yes,
we totally agree that okay, discoloration was one of the reasons for MTA, but by the
bismuth oxide was my problem. I would like to
yes,
use a non-bismuth oxide containing bioceramic.
right, but
Calcium silicates.
yes, so I just want to ask this, that by the time bioceramic were developed, we had newer formulations of MTA which was bismuth oxide free, right? So was there any reason of not using bismuth oxide free MTA but using bioceramic?
Not really. This
I think,
one,
Girish,
the total
if I may help Antonis for that, I would say that Antonis just documented a lot of cases, put them together, give us the information and the report. This is not a clinical trial that we make everything standard and consistent. I do agree with you. If it was a clinical trial, he would have done such a things to make sure that he used same material, same regime of antibacterial or everything or whatever. For example, Professor Ibrahim mentioned about color hexidine as well, which is absolutely true. But it was not just something that was happened. So Antonis just reported that one, which we admire that because he didn't change anything from the reality, which we know that some authors, unfortunately, sometimes make false documents and false idea just to make it better. So I do agree with you. That is a very important point that you mentioned, that in case series even or in clinical trial, we must be consistent. Is it what you want to say, Viresh? Am I right?
Right, but why I was asking this question was because when it comes to, you know, there are certain clinicians and certain people in the world, when they do something, we know there is a reason behind it, you know. So I was just making sure. I was just making sure. Yes, that I don't miss on some information.
There is no conflict of any interest in the materials. In this case, I used this bioceramic because it's a non-staining material and because it's a pre-mixed putty material and the ease of use. It's very easy to use a pre-mixed material. You will see in other cases.
Also, Viresh, I want to add something to that, which I'm happy if others also have some idea about it. I think the idea of telling or terminology of bioceramic, because you are expert in the field, you are doing a lot of research on that. Bebera did a lot of research. Qmers, Nazar Muqaddam did a lot of research on that. When we say bioceramic, it is a matter of terminology and what is the difference between bioceramic, calcium silicates, MTA-like material. I don't see any big difference. Substantially, they are very, very equivalent, Some of them may have a little high, a little more. Professor Abu Tawun is one of the pioneers that started working with Rabinejad ages ago about MTA. So back to that, I think in general, as we can see that Fatima Batul also adds some comment. She did a lot of study. These are bioactive endodontic material in general, all of them, MTA as well. Ibrahim, do you agree with me?
Yeah, and I agree also with Antonis. I think this protocol is more sound. And I think using bioceramics is better. And now, finally, the talk is that about MTA, that it is, stimulates more osteogenic, let's see, healing. While the new generation of bioceramics and all these things, they have more tendency to be used in regeneration, revascularization. Yes. This is what I have read.
Yeah, and in general, as Professor Bebera said also, we should say that hydraulic calcium silicate cements in general, which are all bioactive cements and obviously bioceramic as well. We shouldn't fall in the trap that companies try to tell us. Bioceramics is very nice name, but in general, there is no difference. And also, I think it's important also to make sure we use the material without bismuth, as you already emphasized on that, Viresh, because bismuth is not good. And also the osteogenic activity of MTA that Professor Ibrahim mentioned is very important point. I think these are very important things that we already covered. Thank you very much. Viresh, please.
Right. 3-year follow-up radiograph revealed continuous root development, dentine wall thickening, and hard tissue biological closure of the apical third. The clinical evaluation revealed healthy soft tissues, as you can see on the pictures on the screen. 2 months later, after the initiation of orthodontic treatment, the tooth became painful to percussion. The orthodontist removed the appliances and referred the patient back for evaluation and possible treatment. The radiographic examination revealed a periapical rarefaction. The clinical examination revealed healthy tissues with no probing depths. A diagnosis of rep tissue necrosis was made. The epical diagnosis was symptomatic epical periodontitis. The root canal treatment was performed in 2 visits, and calcium hydroxide was used as an antimicrobial dressing. Obturation was achieved in the 2nd visit by bioceramic putty material. The 1-year follow-up radiographic and clinical evaluation revealed healing of periapical lesion and healthy soft tissues. Coming on to case 3, this case was previously reported as the first successful attempt to repeat a previously failed regenerative endodontic procedure. 7-year-old female was referred with a chief complaint of swelling and pain associated with tooth number 11 after a dentine enamel fracture. At the time of appointment, tooth number 11 was painful to percussion and there was a buccal swelling. Thermal and electric pulp tests were negative. The radiographic examination revealed a periapical lesion associated with the immature central incisor. The pulpal diagnosis was consistent with pulp necrosis and the periapical diagnosis with acute apical abscess. This is important to note here that the initial single-step regenerative endodontic procedures had failed. These are the clinical and radiographic records of this patient. The pulpal diagnosis was rep tissue necrosis and the apical diagnosis was acute apical abscess. The decision was made to re-enter and repeat the regenerative procedure with a 2-step protocol using calcium hydroxide interim dressing for better disinfection. The 2-year follow-up, 3 years after the initial regenerative effort, revealed healthy soft tissues and no symptoms. The radiographic evaluation revealed healing of the periapical lesion, dentine wall thickening, apical closure, and a hard tissue bridge located in the middle third of the root. No signs of regaining pulp vitality were noticed. 4 years later, the radiographic evaluation showed healthy signs. The clinical evaluation was positive. The orthodontic treatment plan consisted of bracketed banded appliances for midline diastema closure due to dental class 2 division 1 malocclusion. 6 months later, that is from the initiation of orthodontic treatment, the tooth became symptomatic and the sinus tract developed. The clinical examination revealed a buccal sinus tract. You can see on the clinical picture here. The radiographic evaluation revealed an extensive internal perforating resorptive defect. A pulpal diagnosis of rib tissue with irreversible infection was made. The apical diagnosis was chronic apical abscess. Decision was made to re-enter and try to arrest the resorptive process with root canal treatment. After removing bioceramic plug, extensive bleeding was noticed. Irrigation was performed with 40 ml 4.8% sodium hypochlorite and calcium hydroxide was placed for 2 weeks to stop extensive bleeding. In the next visit, tooth was asymptomatic and the sinus tract had been resolved. The canal and resorptive defect were dried with suction. The canal was filled with bioceramic putty material and the tooth was restored with composite restoration. The 6-month follow-up clinical and radiographic evaluation revealed uneventful healing and healthy soft tissues with no probing depths. Any questions as of now?
There is actually a question that Dr. Mahjurian asked Antonis in the chat box, which is about why in the second case in the article, nothing mentioned about the orthodontic movement. And because the details of the orthodontic movement, I think is necessary. Reza, do you want to add something to that or it is enough? Okay, Antonis, the question is, he said actually, thank you very much. As you can see already in the chat box, he said, thank you very much for your article. And why didn't you mention the initiation of orthodontic treatment in the second case? I think Viresh also mentioned such a things that in the article and in the details, nothing is written about in case 2 when and the duration or the type of force or anything about the orthodontic movement.
I hope.
And while you're checking that, I think there is also a comment from Professor Nazari Mogaddam about the terminology that we can use for regenerative endodontic healing. It's better to say that guided endodontic repair rather than healing, which I think all of us agree with that these days. And this is a very important comment to know that this is not healing. I think already Professor Ibrahim also mentioned about the possibility of osteogenicity rather than repair by pulp cells. And when we need actually a very proper stem cells for such a thing, so guided endodontic repair can be the very good terminology for that as well. Antonis, just for the second case, an orthodontic movement and the details, have you checked? Yes, please.
What happened? The orthodontic or the orthodontist referred back the patient, and this is very important to make a note that the orthodontics, the orthodontists, they really don't know anything about regenerative endodontics cases. And if you ask, I'm facing huge problems in Greece. I don't know what happened in your countries, but when it comes to a successful case of regenerative endodontic procedure, that the majority of them are related to dental trauma. Usually, the majority of these cases, they concern young patients. These young patients at the age of 8, 9, 10, or 12 years old, during their lives, they will go to an orthodontist, and it's a big, big problem that the orthodontist community doesn't know anything about the movement of these teeth. So they are contacting the clinic, asking me, what should they do with this tooth now? Can I move it? What is the evidence? And this is a huge, I think it's a huge, we need to apply a huge effort in the specialty to and to organize our research efforts to answer these questions, because the doctors, they say, okay, Adonis, you did the regenerative procedures, you saved the tooth. Now what I'm going to do with this tooth? I need a plan. Should I rely on this tooth? Should I? Some of them, they want to extract the tooth because I don't have the support that they all want to a reassurance that they will not have problems with these teeth. So as long as we don't have sound guidelines on the orthodontic movement of these cases, I think we are running into some problems. So here, the orthodontic...
Thank you very much. Sorry, Antonis, to interrupt you. I do agree with all of your comments about the information of other specialty and multidisciplinary approach. Viresh, we go for the discussion.
Thank you. Orthodontic treatment of traumatized teeth is extremely complicated, especially if these teeth have become necrotic and were endodontically treated in the past. For vital, mature, traumatized teeth, it is not sure whether orthodontic movement increases the risk of pulpal necrosis above that of uninjured teeth undergoing orthodontic treatment. For endodontically treated mature teeth, the evidence is controversial, with some studies reporting an increased risk of resorption. Since the time guidelines have been published, the use of regenerative endodontic procedures is frequently suggested for the treatment of traumatized immature teeth with arrested root development. The primary objective of these procedures is the healing of apical periodontitis, followed by the formation of vital tissue into an empty but previously infected root canal space that will induce continuous root development and dentine wall thickening. Regaining pulp vitality is the ultimate objective for immature teeth with arrested root development. The lack of dentine pulp regeneration in animal and human studies following current regenerative protocol suggests that the regeneration of the pulp dentine does not occur, but rather connective tissue with cementum-like mineralization appears to occur. The findings included ingrowth of periodontal connective tissues into the root canal space that contain bone-like tissues and the formation of cementum or cementum-like tissues on the dentinal walls. Little is known about the long-term response of regenerative endodontic procedure tissue in orthodontic movement and the bacterial insult. In recent national survey of UK-based orthodontists, the management of regenerative endodontically treated teeth was reported to be largely unknown to the majority of the respondents. Currently, only 3 case studies reported orthodontic movement of regenerative endodontic therapy treated teeth, which exist in the literature. In the first case, the application of mild orthodontic forces improved the remodeling and repair of apical tissues following a single-step regenerative endodontic procedure. The author concluded that under certain circumstances, mild orthodontic movement might improve the periapical repair of regenerative endodontically treated teeth. In the second case study, although the orthodontic treatment of the patient with a rep-treated tooth was highlighted as successful, some concerns was raised by the authors. The long-term effect of orthodontic movement on the cementum-like and bone-like tissues surrounded by connective tissue that had been shown within the root canal system of rep-treated teeth is currently unknown. In their case, to ensure minimal orthodontic forces, the functional appliance therapy had been performed with no active or retentive components in contact with the rep-treated tooth to reduce the risk of possible complications. Moreover, the rep-treated tooth was kept off the arch wire during the fixed appliance therapy to reduce the orthodontic forces. The authors reached to some recommendation guidelines for the active orthodontic movement of rep-treated teeth. Regular close monitoring of the rep-treated teeth throughout the course of the orthodontic treatment, partial or complete exclusion of the rep-treated teeth of orthodontic forces, or light short-acting forces which are less than 70 grams. Sorry, the less than mark is missing here. Sorry for that. Might reduce the risk of long-term complications. In the third article, the tooth treated with rep was included in the orthodontic treatment plan and responded to the orthodontic treatment similar to the non-endodontically treated teeth. According to the guidelines of European Society of Endodontology, in the case of planned orthodontic treatment, teeth after revitalization may be more susceptible to inflammation and apical root resorption. Thus, bony healing should be awaited, and teeth after revitalization should be excluded from orthodontic treatment, or follow-up intervals should be shortened during the orthodontic treatment. In the first case, the first long-term complication associated with trauma, rep-treated tooth, and orthodontic treatment is the severe external invasive cervical resorption. The rep procedure followed in this case used 2% chlorhexidine as a disinfection agent in a single visit approach following the single step regenerative protocol suggested from a case report that was published at the time of this case was managed. Some years later, chlorhexidine was shown to be toxic for the survival of human stem cells in a platelet-rich plasma scaffold, and it was excluded from our regenerative disinfection protocol. Although the intruded teeth had regained its vitality 5 years after the rip, the application of mild orthodontic forces might have triggered or accelerated a previously initiated external invasive cervical resorption.
Exactly.
Interestingly, tooth number 11, which had been treated with an apical MTA plug technique, showed no signs of pathology. These different long-term outcomes reported here might be due to a different severity of an initial traumatic dental injury. Moreover, the distal defect of the lateral canal wall of tooth number 21 might also contribute to the devastating complication reported here and act as an entry point for the cervical invasive resorption process. So here I wanted to actually discuss with the author that he has very nicely documented the importance of CBCT in this case, which the parents didn't want because of the exposure and surgical intervention because the child was uncooperative. So, but if given a choice, what does he think? Would intervention would have helped surgical intervention here?
Maybe if you could have a three-dimensional imaging and you could confirm the initiation of an external resorption defect, maybe a surgical intervention would be able to save the case. I mean, to surgically repair the defect and keep the tooth in the mouth for more time. I think the point here that was it was my bad judgment and didn't continue to follow up the case. I mean, I stopped following up this case at 5 years. That I thought I had a successful regenerative attempt, but you know, with this kind of cases, you never know. Long-term complication of trauma cases can be really.
I feel I am just jumping off to the conclusion slide. I am not, but here I feel it is important to add that whenever we treat such cases, is it a good idea to inform the patient also that in case you are going for any other treatment on this particular tooth, then it will be a good idea to either follow up or inform your previous dentist, something like this, so that this means in the guidelines, patient should be made aware.
I think this is the most important things that Viresh raised, and in the chat box also there are some comments about that. I think if I put all these comments, and I ask Antonis to read the article, the comments in the chat box as well, but these are the good things that Professor Kayahan and Professor Nazari Moghadam wants to raise, that when we have a tooth with the previously treated regenerative endodontic procedure, maybe better not to permit the application of orthodontic force on them, and also the type of the orthodontic force. Even though you said that the orthodontist, they didn't give you the information, but it is necessary to think about some sort of even animal studies to compare the type of orthodontic force and the effect of them. If we increase the force or decrease the force, they may have different effects as well. And if also possible, not to do orthodontic movement, but just doing composite filling or other types of aesthetic dentistry, rather than doing the orthodontic treatment, that would be a good idea that Professor Kayahan mentioned. Also, there was another comment, very good comment, that when we have trauma, they are already susceptible to a lot of problems after orthodontic forces. So as you already mentioned in the discussion and Viresh emphasized, I think these are the very important take-home messages that we can get from this amazing discussion. Thank you. Viresh, please go ahead.
In addition,
Professor Ibrahim has a comment. Please, Professor
just
Ibrahim.
Just to add to what you have said, but we remember only as early as 1927, yes, 27, a very good study that compared radiographically the tooth, the root of teeth before and after endodontic treatment and orthodontic movement. And they concluded that the main cause for resorption in these cases was orthodontic treatment. And the study of Tronstad also, very recent study, who found or who concluded that around 43 of endodontic littered teeth that have been subjected to endodontic treatment will suffer from resorption in 5 to 10 years. And this is why I'm trying to compare it with this study. This is excellent study and honest study. And most important, recently, they are advising that if you're going to go for movement, orthodontic movement, don't complete the root canal treatment. In the active stage of treatment, just place and rechange non-sitting calcium hydroxide and carefully monitor the case. This is the new advice I have read finally. But I think that this study is excellent because at least it opens our minds and our concept to what might happen and to the risk we should recognize that all teeth at least may be subjected to resorption following root canal treatment and orthodontic movement during the movement period. And we should be careful of that. This is what I wanted to add to.
Thank you very much. Thank you very much. Very nice. Viresh, please.
Sure, I'll just continue. Before the initiation of the orthodontic treatment, the lateral wall defect was monitored regularly with periapical radiographs and considered stable throughout the 5-year follow-up period. The use of further CBCT evaluation or surgical exploration was considered unjustified during the monitoring period. So probably here I feel that if more was relied on periapical radiographs and if parents had agreed for CBCT evaluation, I feel things would have taken a turn. This is what I feel. The orthodontic forces applied here might have acted as the trigger point needed to initiate the resorptive process. In the second case reported, apical periodontitis and rep tissue necrosis were diagnosed after the initiation of orthodontic treatment. The lack of dentine pulp regeneration in animal and human studies following current regenerative protocols shows that the regeneration of the pulp dentine does not occur, but rather connective tissue with cementum-like mineralization appears to occur. The findings included ingrowth of periodontal connective tissues into the root canal space that contained bone-like tissues and the formation of cementum or cementum-like tissues on the dentinal walls. So I just, at this point of time, I just wanted to say that when we are talking about, pulp vitality, and at the same time, we are saying lack of dentine pulp regeneration. So how do we connect these things here?
I think you just get readings from the nerves. That's it. It's not a pulp tissue. It's a pulp-like tissue. So you just get a response from the neural tissue that is growing somewhere inside this previously infected but now disinfected root canal space.
Yes.
So, but then is it right to call it as pulp vitality when the tissue is only not pulp?
Not really. No. It's not. I don't believe it's pulp vitality. It's just a neural response. Maybe we should find another terminology for this.
Exactly.
But
Then probably.
I continued the same mistake that was mentioned in the beginning in the early case reports, that I believe it was mostly to make an impression. Then it's not pulp vitality. It's just a positive response that sometimes, it cannot be reliable because it's kids. We are dealing with children, and it can also have this kind of.
So probably it would be right to say that if we replace the term by neural response, that's it. That the neural response was positive.
Yeah. Maybe
Yeah,
yes.
I think the comment that received from Professor Nazari Mogaddam is very interesting, that these are free nerves ending that are attracted to the regenerated pulp space by a process called axonal targeting that is likely mediated by cellular and non-cellular activity. So this is very important. So I think Antonis already confirmed that this is just nerves, not vitality.
Yes.
That is a very good point. Noted.
Very nice.
And during the orthodontic treatment, cellular enzymatic or these things, what occurs in a particular in the tooth that is undergoing an orthodontic treatment. These are the changes which are listed on the screen. And then the induction of pulp tissue necrosis after orthodontic movement is rare, with a very low level of evidence. But I feel, Dr. Antonis, if these, I think these, we say the induction of pulp tissue necrosis after orthodontic movement is rare. But if you see the list which has been given here, I probably feel the final destination is pulp tissue necrosis only, in one way or the other. If we go from circulatory disturbances, induction of tissue fibrosis, pulp calcification, these all are actually leading to, damage to the pulpal tissue.
And but it's not a pulpal tissue here.
But the thing is, we are talking about the evidence, Viraj. We need to be very careful. Speaking about the evidence is different from speaking about some reports. Even for regenerative endodontic procedure, still, as Antonis mentioned, we don't have enough evidence. For evidence, we need to run some very, very standard study. That is, we have lack of evidence doesn't mean that we have lack of the reality. The reality is different from the evidence. This is important. I think you should emphasize on that. We already, I think, emphasize on the lack of enough clinical evidence in endodontic literature. Comparing to other literature like periodontal literature, we can find a lot of evidence, a lot of high-level evidence. But in endodontics, I think we should say that, unfortunately, emphasize on the clinical part and on the technical part more than on the evidence-based endodontic treatment, which is very sad on the other hand as well.
Right.
And maybe a pulp tissue can survive the orthodontic forces, but the tissue that we have in regenerative endodontic procedure, I think it's very hard to survive under the stimulation of orthodontic forces. I mean, we are not sure what kind of tissue it is or how this tissue will behave after the application of orthodontic forces. And I will leave you finish, because I think the most important thing the most important point of my paper is that I never expected to experience an internal resorption defect in a tissue that was somehow regenerated inside a previously infected root canal space. And this is something that really shaken me and made me think again and again what actually we're trying to do with regenerative endodontic procedures. Okay.
Yes, but the thing is, speaking about the external resorption, we need to be very careful, or even internal resorption, the mechanism is absolutely different. So we may discuss that in the future and think about doing and running different studies about the source of the resorption, what type of cells are going to do that. And I think that one of the very, very important comments is what we have received from Professor Ibrahim about the osteogenic activity comparing to the true regeneration. And when we have osteogenic activity, that means we may have osteoclast, but hidden osteoclast and silent osteoclast waiting for induction of some trigger, which orthodontic movement can be the trigger, although we need the evidence. As Viraj said, still we have lack of evidence. That is very great. Viraj, please.
Yeah, complete necrosis of the rep tissue was verified after assessing the tooth. Besides orthodontic movement, residual biofilm infection because of inadequate single visit disinfection might also account for necrosis of the rep tissue. Although single step regenerative procedures may favor maintenance of the vitality of the apical papilla and might enhance patient compliance, lower clinical success rates have been reported in cases of immediate blood clot induction compared with delayed induction protocols. So I think these are the key keywords.
Thanks to Antonis that he already covers this criticism of one visit rep, which is already covered.
In the third case reported, an internal resorption defect was surprisingly identified 8 years after the initial trauma in previously successful regenerative procedure. The inflammatory resorptive process had been initiated and progressed during a period of 6 months after the last follow-up and after the initiation of orthodontic treatment. For vital pulp tissue, the damage to the odontoblast layer and predentine of the canal wall is prerequisite for the initiation of internal root resorption and might be induced by the orthodontic movement. For rep tissue, the odontoblast layer and predentine in the canal wall are lacking, making these teeth potentially vulnerable to internal resorption. For the initiation of internal resorption, it is suggested that odontoclast might bind to extracellular proteins containing the arginine glycine aspartic acid sequence of amino acids via integrins. Extracellular matrix proteins containing the arginine glycine aspartic acid peptide sequence, such as osteopontin, serve as binding sites of clastic cells and resorptive process might be initiated. Osteopontin, also found in rep tissue, serves as a linker molecule that optimizes the attachment of clastic cell to mineralized tissues. The osteopontin molecule contains different domains, with one domain binding to appetites in the denudentine and another domain binding to integrin receptors in the plasma membrane of clastic cells. In the recent case report, rep tissue histology revealed neomineralized tissues interlocked into pre-existing dentinal tubules rather than a newly formed pulp-dentine complex. Non-odontoblast looking cells express different proportions of osteopontin and dentine sialoprotein according to their location. Cells nearer to the MTA barrier expressed dentine sialoprotein and osteopontin, but cells found apically express predominantly osteopontin. So I think this is an important point to keep it in mind. It is speculated that under proper stimulation and bacterial invasion, internal resorption might be initiated with the same binding mechanism in rep cases as in vital pulp cases. Orthodontic movement might play a significant role in the initiation of internal resorption long after successful rep outcome. So based on the complications reported here, some recommendations can be suggested to avoid such mishaps. First is detailed informed consent warning about the possibility of external invasive cervical resorption, necrosis, or internal resorption after the active phase of orthodontic treatment. Modifications of the treatment plan to exclude, if possible, the red treated teeth from the orthodontic forces. throughout the whole course of orthodontic treatment, close radiographic and clinical monitoring is necessary by the doctor who provided the initial rep procedure. If signs of resorption of necrosis are detected, the application of orthodontic forces should be ceased immediately and early management may be required.
Very nice.
In this, I think we can also add, if I may not be wrong, the best advice can be given by the author. I think we can also add that we can actually, request or give a guidance to orthodontists here also, that in case you are starting an ortho treatment and you see on an OPG where such procedures have been performed, kindly make an effort to ask the patient who your endodontist is, where this procedure has been done, and a good communication can be created. I don't know how far it will go, but a good communication can be created so that in the whole scenario, patient is in a winning situation. Patient does not suffer. I mean, if
yes,
this
I think this is very important, very important. Communication between orthodontics and endodontics is very important. Antonis already mentioned that there is a difficulty for such a things in Greece for him. So he already covered this as well. But I think it's good to add that in multidisciplinary treatments, we need a very close communication with each other.
Right. So in the end, I would like to thank everyone and thank the author, thank everyone present here for this wonderful opportunity to critique an article written by a good friend of mine, and thank you everyone. That's it.
Yeah, Viresh, thank you very much. You did a great job. I know that you are visiting your family in India but not working, so this is very good to give us this opportunity to use your amazing thinking, amazing criticism, very nice way. And I think we had a very fruitful discussion today. And let us add 2 or 3 comments that we have received. First comment, or the last comment, is from Professor Kayahan. As far as I know, the guidelines of Dutch Orthodontic Society advise to stop forces for 6 months case of resorption, but has to be confirmed. This is also, and there is also another comment from Professor Nazar Mogaddam about different types of outcome, clinical centered, scientific, scientist centered, or patient centered outcome of regenerative endodontic process, which is absolutely true. And yes, this is important to know that why what we are doing for patient outcome, this is different from what we are looking at as a clinician. And when it goes to the scientific level, obviously, the last part of the discussion was very interesting, speaking about the resorption process that you covered very well, Viresh, as well. There was the last comment from Professor Kayahan about when we have calcification and survival of the tooth, maybe this is sometimes for the patient's outcome is enough, and we need to be careful about application of the orthodontic force, and maybe making some laminate or some composite is enough for the outcome of for the patient. Okay, thank you very much indeed from all of you. And I'm sure there are a lot of comments and discussion, but I want actually to say our appreciation, and on behalf of the educational committee and on behalf of the Tehran University of Medical Sciences, Professor Kim as the president, Professor Miglani as the dean of the educational committee, and Professor Ayati, the vice chancellor of Tehran University of Medical Sciences, we are going to put our hand together for Antonis Juantus, our big friend, very close friend, and say thank you very much for publication, such an amazing thing. So this is the certificate of appreciation to you, Antonis. And also we are going to share to our amazing friends, our honorable friends, Professor Viresh Chopra, who is also a very, very good scientist. He is doing a lot of research. Also, our appreciation from Professor Kim, the president of APEC, Professor Sanjay Miglani, and Professor Ayati, the vice chancellor of TUMS, to you, Viresh, for accepting to be our appraiser today. You did a great job by covering a lot of things in a very polite way to Antonis. And I should appreciate Antonis for accepting the comments and scientific notes from everyone and you as well. Okay, if there is a comment, I think Talal is going to add something. Talal, do you have a comment? Please go ahead.
Really, it was very interesting 2 hours. Thank you, Antonius. Very nice, well-written article. Thank you, Veresh. And I want to add something to speak from orthodontic point of view. Even we have some complications related to endodontics. Even, for example, let's say we had a successful regeneration, guided regeneration.
Oh, I think Talal is disconnected just in the middle of his comment. Talal, can you hear us? Okay, I think while we are waiting for Talal to come back, if there is any other comment, Professor Nazar Muqaddam, do you want to add anything?
Moving, especially if
okay, Talal is back.
Okay. So the main idea is whenever we have a successful regeneration, for example, let's say we have a dentine like tissue inside the root, or a bone or cementum like tissue, and we don't have fibrous, for example. This, on the orthodontic point of view, I think will make the movement more difficult. So also we have to think from orthodontic point of view, not from endodontic point of view. It was very interesting to see also the next idea that we have internal resorption, which means that you regenerate something inside, which will have live cells inside to induce the internal resorption. But on the other hand, why not to make apical plugs and to have no tissue inside to prevent the potential of having internal resorption? On the other hand, you will tell me doing reps will increase the thickness of the wall, will increase the length of the root, which will make better prognosis for the tooth. But on the other hand, we have to understand that the reps will not induce more thickness of the dentine in the most important area, which is the pericervical dentine. We are not increasing the thickness, so pericervical dentine is very important for the long surface of the tooth. So I think we have to think twice and for the third time about reps, and especially for orthodontic treatment. Thank you.
Very nice comments, Talal. Thank you very much. To make it very quick, but you cover a lot of important things. And I think if a tooth candidate for orthodontic movement, we need to think about doing the rep or not doing the rep. As you said, apical plug may be better choice. I think Antonis already covered that in the first sentence of his talk, that he said that case selection is very important. I think this is very good. This is very good. Kumars, do you want to add something very quickly?
Thank you very much for Prefect webinar, and also Antonio for his presence in this webinar. I think I learned a lot about the resorption after this procedure, and this webinar is so useful for residents, but I can't see any of them in this webinar. We have very, very good discussions, and I think this webinar will improve our knowledge to open a new area in the regenerative endodontics. Thank you very much, Professor Lekuva.
Thank you very much, Kumars. Before I ask Professor Ibrahim Abu Tahun for his closing talk, because this is the tradition of this online journal club that we ask him, I'm going to ask Baber Akayahan, Professor Baber Akayahan, to have his talk. Professor Baber, please.
Thank you, brother. Thank you, Professor Nekofar, and I'd like to thank all who participated in this perfect discussion. I'd like to thank once again to Dr. Antonis Chaniotis and Viresh Chopra. And thank you very much. You are doing a great job, Professor Nekofar, as usual. Thank you very much for this nice discussion. I hope the next one will be in a few months and a few weeks, and see you there. Thank you very much.
Thank you very much indeed. Prior to Professor Ibrahim, please watch a video, and then Professor Ibrahim is going to close the session. Zohre, please.
Hi guys, against all odds and whatever happened because of the pandemic of COVID-19, we are here for the 20th Congress of Iranian Association of Endodontics. On behalf of our associations, as the president of this Congress, I'm honored to invite all of you to join us to 20th Congress of Iranian Associations of Endodontists, in which we are going to host more than 15 international lecturers as well as 150 national lecturers. We are having a lot of hands-on courses, exhibitions, and a lot of fun attached to our Congress. Join us the last days of September in Iran, Tehran, for the 20th Congress of Iranian Associations of Endodontics.
Okay, thank you very much for watching this. So this is a informal invitation, but all of you are going to receive our formal invitation very soon. Looking forward to see all of these amazing lecturers, amazing faces in Tehran. So, and as we said in Persian, please put your foots on my eyes. Thank you very much and see you soon. Professor Ibrahim, please.
Well, thank you, Dr. Mohammed. A great session with you and with your guests, Dr. Antonis and Dr. Virish and all the others. When I was a student, I have been taught that orthodontic treatment usually enhances and improves, it speeds up the healing in cases of periapical lesions. In my own clinical experience after I started practicing dentistry, I found that this is true to some extent. But I don't know, lately, I have noticed that most of the patients who come to me with external resorption, usually they have been undergone orthodontic treatment. And as you know, we should stop or we should discontinue orthodontic treatment in these cases. I don't know, maybe they want to finish quickly, I don't know what. But on the other hand, I've treated many cases with open apices using the old classical apexification technique with non-setting calcium hydroxide with the high rate of success. I still believe that the excessive orthodontic force may be to some extent a reason behind all these failures. Because as I told you, one of these studies found that around 43% of teeth that were undergone root canal treatment and orthodontic treatment have ended up with external resorption compared to just 3% of cases just with pulp necrosis and periapical lesions, which indicates that orthodontic treatment plays an active role in resorption in these cases. Again, I want to end up thanking Dr. Virish and my brother, Dr. Antonis. Thank you for your honesty. I think this is the best way to learn from our mistakes, not from our successes. And this is the importance of such discussion about failures, not successes, because this is the only way to get back to the right track. Thank you, all of you, and looking forward for the next Mohammed Journal Club. Thank you all very much.
Sorry. Thank you very much, Professor Abu Tahon. You always are very supportive, and thank you all for being with us. Antonis, again, thank you, and Virish as well. Okay, see you in a month for our next online journal club, and see you in Tehran in the last week of September. Thank you very much. Have a very nice evening. Goodbye, everybody.
Bye.
Goodbye.
you.